Joanne, live na tayo. Joanne, naka-unmute na ako. Naka-unmute na ba ako? I-unmute mo na ako. Kaya nga, hindi ba ako pwede ma-unmute na?
Naka-ready na yan eh. Pero 1 minute na.
Wala yung countdown.
Wala mag-echo.
Good evening, everyone. Welcome to the Philippine College of Physicians webinar series entitled Longevity, a webinar series dedicated to improve lung health. Through a partnership with MSD, we will be now showing you series of webinar activities designed especially, I think, by serendipity, especially designed during these moments of extended community quarantine. I think it is especially during these times that we really need to be updated as far as our approach to certain diseases modified to a certain extent because of this pandemic that we are facing. So for this first session, we will be having bacterial pneumonia, finding and treating the hidden threat behind COVID-19. I think in a way, this is quite timely, especially since as physicians, we are encountering bacterial pneumonia. But because of the presence of this pandemic, we to a certain extent need to modify our approach. What is it that may have implications or influence in terms of our treatment approach? Those are the concepts that needs to be threshed out, especially during these times. And we are quite fortunate to have an ID colleague to talk as far as bacterial pneumonia is concerned, and I will introduce him later on. And hopefully at the end of the talk as well, I'll give you certain pulmonary perspectives, what makes this disease entity quite challenging considering this COVID-19 brouhaha. So just a few reminders to everyone. We would be entertaining comments and questions at the end of the session. So please put your comments and questions at the comments section. and for us to have a more smooth transition, especially during these technical times, we are reminding everyone to please mute your microphone and sound so that we can be hearing the speakers talk very well. So it is indeed my pleasure to introduce a good friend, Dr. Ron Ginsolante. He is the current chair of the Adult Infectious Disease and Tropical Medicine of San Lazaro Hospital, current chair of the Infectious Disease section of the UERMMMC, and a board of regent of the Philippine College of Physicians. A past president of the Philippine Society for Microbiology and Infectious Diseases, and I really look forward to his perspective as far as bacterial pneumonia treatment approach is concerned, especially during these times. So take it away, Dr. Solante.
Thank you, Jubert, for that kind introduction. Let's go. Okay. So as mentioned by Jubert, the focus of the first topic will be on bacterial pneumonia and how to find and not necessarily how to find, but how to treat and what is the current approach to your patients with COVID-19. Scope of the discussion will be what is the current situation now in terms of the data, both global and the Philippines, and the past 2 to 3 months, we now have a better understanding of the disease progression, how those patients will become severe who are at risk of poor outcome. And these are also the important population that we need to focus because these are also the patients that are at higher risk of mortality. And then we'll also review what are the core clinical management that we are following now in the management of our patients with COVID-19. And lastly, uh, reviewing data, what is the rate of secondary bacterial infections and how to treat what specific antibiotic and what antibiotic or why are you giving those antibiotics. As of April 20, this is the current situation of the numbers of infected. Globally, there are already around 2.3 million confirmed cases and 157,000 plus deaths. And among the different regions that has the highest density, including the number of deaths, it's the European region, followed by the region of the Americas. In the Western Pacific region, the Philippines is in the seventh, with China as the first, followed by Japan, Korea, Australia, and I think you know that Singapore has the resurgence of cases for the past week. And the Philippines, as of today, we now have 6,710 cases. And then among these, there were 446 deaths registered and then 693 recovered. For this day alone, the new cases that were confirmed were 111. But you know, the fact that these are not real-time data because of the delay in the submission of the specimen. So there's always a lag time of 2 to 3 days. Now, uh, based on the current demographic of our patients or patients with COVID, you'll notice that more than 50% of those confirmed cases are in the 50 years old and above. So, since they are also the high-risk population who develop more severe clinical manifestations than most, these are also the age population or age group that are also admitted and command highest rate of death. And male population are higher than female. For whatever reason it is, we don't know, but there is a higher prevalence of COVID-19 among male over that of female. For the past months, we have understand that clinical progression is driven by the different pathophysiologic events that occur in our immune system, from a very mild symptom during the first 7 days, And on the second phase of the infection, during the second week, you have the patients developing mild to moderate pneumonia, and then the overlap among patients with severe pneumonia and critical. And this is something that we have to understand because this at this time of this chronology of the manifestations, there is also here the appropriate clinical management that they have recommended among this group of patients, particularly when a patient is in the phase of critical phase, wherein this is mediated by an event we call cytokine storm, wherein you also will be giving a lot of these immunomodulatory drugs in order to temper down the effect of your cytokine storm. And this is also the phase where most patients have a higher risk of mortality. Now, based on several of these articles reported in Wuhan, uh, majority of patients with COVID usually have mild to moderate symptoms. And in fact, you've heard a lot of these articles now that they now change the word asymptomatic to pre-symptomatic. And there are also data that will tell us that even at the 2 to 3 days before the appearance of symptom, particular individual can also be transmitting the virus. And then at the other end of the clinical manifestations, you have the severe form, around 20%, and 5% of this will go into the critical phase. And then, as what we have mentioned in our demographs, which is also consistent with the case fatality in abroad. This is reported by MMWR. This is data coming from the US, in which the risk of mortality is really very high, which starts at 50 years old and then exponentially or subsequently becomes higher as you age or as your age is you grow older. Like in 85 years old, you have a higher risk of death, which is like uh, 20%. And we also experience this now in our local patients, especially in San Lazaro Hospital, where the youngest among our mortality is 44 years old, and the oldest is 89 years old. And 70% of our mortality are those patients between 70 to 89 years old. Now, the presence of comorbidities has been established as one of the factors that can also increase the risk of mortality. And the most common um, comorbidity that has been associated with this infection are those patients with cardiovascular diseases. And then this is followed by diabetes, chronic respiratory disease, and cancer. Now, looking at the different immunological event that goes with this infection, as I mentioned a little while ago, when once a patient becomes is in the severe form of the infection and then going to critical, this is usually characterized by dysregulation of the immune system. And this can be documented by the presence of your different pro-inflammatory cytokines, including chemokines, that will now be the mediators of an abnormal biochemical and physiological changes in our body that will be elicited in the form of increase in the neutrophil, increase in your liver enzyme, increase in your CRP, ferritin levels, and the other cytokines and chemokines. And most of the studies identified three very important predictors of mortalities based on these laboratory abnormalities. You have your D dimers, those with lymphopenia, and those with highly elevated C-reactive protein. Now, we need also to understand that the clinical course of patients with COVID is quite different from those who survived and those who did not survive. If you look at this particular data, which was initially submitted during the first 3 months or the first 2 months of those patients in Wuhan, among those survivors who were discharged, the event that usually transpired and the critical event that usually transpired in the course usually starts on the second week. Okay? And among those in the non-survivor group, aside from sepsis, once you develop ARDS, this is already the culminating the initial phase of the infection, wherein it will be followed by effect of multi-organ dysfunction in the form of a cardiac injury, kidney injury, and then if the patient could survive, then this is also the time that a secondary bacterial infection, usually hospital-acquired infection, will set in. And then eventually, if the patient will not be able to survive in this event, then higher risk of mortality before day 20. And these are the common complications identified. Sepsis, you have ARDS, and then you have the other multi-organ uh, dysfunction. A paper was also submitted that they also identified some in the previous slide that was mentioned that these are consistent among the mortalities that has been experienced among these patients. Age is one of that. The older your patient is, the higher is the mortality. Second is the presence of underlying disease. Third is the presence of secondary infection. And that is what we're going to talk about. What antibiotic and why this antibiotic is important, because we know that the presence of secondary infection is also a predictor of mortality. And of course, I have shown you the elevated inflammatory indicators that will also are correlated with higher risk of mortality. So currently, the treatment is usually supportive. Okay? So you give oxygen, and if the patient needs intubation, then you have to support it with mechanical ventilation, and then you have also conservative fluid management. And one of the approach here is really giving empiric antimicrobials and also giving empiric anti-influenza agent in the form of your oseltamivir. There are reports that steroids may be beneficial in a subgroup of population. Probably Jubert can explain this later. And while giving all of this, you have to monitor signs of deterioration and identify and manage other comorbidities while you are taking care of these patients. So I'll be showing you the algorithm on the referral and triage. The essence of this slide is we need to know who among your patients, upon seeing them and examining them in the triage, will have to be admitted in the ICU. That's the priority because most of those patients, especially for the elderly, even presenting with mild symptoms, or those initially presenting with decompensated clinical manifestation, then they have to be admitted in an intensive care setting where you also have an automatic referral with pulmonologists, critical care specialists, intensivists, and the other subspecialty in order to address the multi organ dysfunction or to predict or to anticipate the multi-organ event of a particular patient. Now we focus on the role of antibiotics in COVID-19 management. And this data article somehow summarized that the role of antibiotics is important. One, because it's very difficult to distinguish between bacterial from viral pneumonia. Second, if you have an initially viral infection that can affect your immune response, and then that can also lead to bacterial pneumonia. And most of the data will tell us there's a secondary infection during the second week of the clinical course of COVID. Then there's also a possibility that both of these infection can set in, meaning a viral plus a bacterial infection at the onset or acquired during the acquisition also of the virus in the community. And the mortality that has been identified aside from the COVID-19 is also that those patients who had a superimposed bacterial infection also have a higher rate of mortality. But for the past 2 to 3 months, there are a lot of questions because based on the dearth of data that microorganism or bacterial infection has not really been very significant in terms of being isolated in most of these patients, then there's also an area where probably most of us are over-treating our patients. And that's the reason why that once the patient clinically improve and there's also result of the bacterial culture, then rapid de-escalation is also one of the important aspect in order to preserve the and lower the risk of drug resistance while treating these patients. The Surviving Sepsis campaign has somehow mentioned that there's a specific population of patients in which antibacterial agents is important. And these are the patients that are ventilated or those patients who develop respiratory failure. This is based on their study that in one article, critically ill patients demonstrate the secondary infection in about 11% of cases. And the most common organisms identified here are Klebsiella pneumoniae, Pseudomonas aeruginosa, and Serratia marcescens. Mostly are gram-negatives, and there are also risk factors that can also pinpoint to the possibility of Staphylococcus aureus infection. Now, can you differentiate a viral pneumonia from bacterial pneumonia? As I've mentioned, it's quite really very difficult. But there are also some areas here that are really specific for COVID or more or less common in COVID, and there are also manifestations that are specific for bacterial pneumonia. Like for example, in COVID pneumonia, most of those patients will, aside from the typical symptoms of COVID, you have patients with presenting with severe myalgia, you have a loss of sense of smell or anosmia, and you have a feeling of breathlessness but has no pleuritic pain. And of course, exposure history is also very important. If you have a patient that has a higher risk of being exposed to a known COVID patient, then that can be a clincher that this patient has COVID pneumonia. While that for bacterial pneumonia, uh, the clinical course is usually rapid, unlike with COVID pneumonia. At the same time, they don't have history of typical COVID-19 symptoms, and most of the time they have pleuritic pain and also purulent sputum. But somehow, some of our patients, as we have observed for the past months, some of this may have an overlap among these patients, and that's the reason why it's really very difficult to differentiate if this is just a COVID pneumonia or a bacterial pneumonia, especially for patients presenting with severe or critical phase of the infection. This is the data that they have suggested that among patients with severe COVID manifestation and who did not survive, 50% of those had secondary infection, meaning they did not survive 50% because of the presence of bacterial infection. And I think this was the reason why the clinical guideline has more or less focused on this severe type of patients that you need to give a broad spectrum antibiotic to cover for gram-negative, gram-positive, and also looking at your antibiogram in your community. Now, would just like to share with you that the first COVID-19 infection in the Philippines, this was published 2 weeks ago, and these were the patients admitted in San Lazaro Hospital. The first patient was a 39-year-old female, Chinese, who had cough and sore throat. So we did an NPS, OPS, PCR, and it revealed the presence of influenza B, presence of Staphylococcus aureus, and Klebsiella pneumoniae. So this was the first confirmed COVID case in the Philippines. This patient survived. Her partner, the 44-year-old male, who really progressed to moderate to severe and then critical phase of the infection, initially present with fever, cough, and chills. Then when we did that NPS, OPS, PCR, so it's not the usual sputum bacterial culture, we did a PCR, care of RITM, it revealed influenza B, Streptococcus pneumoniae. So this was the first COVID-19 death outside of China. Another article mentioned the presence of co-infection, and I think as high as 20% were positive among those diagnosed with COVID pneumonia, uh, harbor one or more additional pathogens. So the most common co-infections identified here are mostly viral, including your non-SARS-CoV coronaviridae among these patients. Then IDSA mentioned the evidence of secondary bacterial infections in patients with pneumonia. And this is quite significant because among the 41 patients that were involved in this particular study or retrospectively reviewed, 10% had secondary infection. And majority of those patients who had secondary infection, again, consistent with the other data, are admitted in the intensive care unit. Another data revealed that among the bacterial culture that were isolated among patients with coronavirus infection, it involved superbugs, meaning these are microorganisms that are drug resistant, specifically your A. baumannii, Klebsiella pneumoniae, and in fact, they all were able to isolate also Candida glabrata and Candida albicans. implication here is when you have all of these bugs, especially those who are drug resistant, then it can add up to the risk of mortality because of poor response. This is the other guideline from that article in which they only select the administration of broad spectrum antibiotic and a neuraminidase inhibitor in the form of your oseltamivir among patients who may have severe form of COVID-19. And the fact that these are severe, then you really have to cover also for bacterial and viral agent. And then another data in which they also recommend the use of antibiotic among selected patients, again with severe form of COVID infection. Now, this is how our local guideline looks like. So it starts with assessment, presence of based on physical examination, and then age. So meaning if the patient's age is less than 60 years and absence of comorbid conditions, then they will be classified as mild to low. Okay, so I will show you what is A, B, C, and D later on. Now, if the patient is more than 60 years old and with any comorbidities, then they will be classified as moderate to severe to high risk. Okay, so currently, these are the investigational drugs that we're giving to our patients: the chloroquine or the hydroxychloroquine, including the antiviral agent for against HIV, the lopinavir, ritonavir, and then for those with worsening clinical manifestations, we're also giving the tocilizumab. So this is how our guideline will look like. Okay. So if a patient is less than 60 years old, absence of comorbidities, then you don't need to do recommended diagnostics. But I think we have revised this one that as much as possible, presence of symptoms, as long as you have the testing or the accessible testing laboratory, then you have to also document the presence of COVID among these mild cases. But you don't need to give antibiotic. For the group B, those with adults 60 years and above, but with stable comorbidities, then these are the recommended diagnostic tests. Chest X-ray is here and chest CT, and then they will be treated with antibiotics in the community-acquired pneumonia low risk. In classification C, these are the patients with respiratory rate of more than 30, severe respiratory distress with O2 oxygenation of less than 93% at room air, and then those with severe organ dysfunction or patients with sepsis, then this is now the overlap between giving your moderate risk antibiotic and that giving your high risk antimicrobial. And these are your diagnostic tests. So what are the antibiotics that are currently recommended? And this is based on the updated guideline of the PSMID. So for those with B symptom or the low risk, since they can take oral medication, so the choice of your amoxicillin 1 gram 3 times daily, or clarithromycin 500 milligram twice daily, and azithromycin 500 milligram once daily. Now, for those with comorbid illness but stable, then a beta-lactamase inhibitor is given, and then cefuroxime 500 milligram twice a day, with or without the addition of your clarithromycin, azithromycin, or doxycycline. Once the patient is in the C classification, where you need to admit this patient in and closely monitor, then these are in the moderate risk community-acquired pneumonia. And these are the first-line antimicrobial. You have your ampicillin sulbactam as high as 3 grams every 6 hours, cefotaxime, and then ceftriaxone 1 to 2 grams daily. And then you have to have your macrolide in the form of your azithromycin and clarithromycin. Now, for patients who belong to C and D, meaning they are now in the severe and critical stage, then you have to ask if there are risk factor for drug resistance. And the most important risk factor here is the receipt of IV antibiotics for the last 3 months. So if none of that is present in that particular patient, then you may still have to give any of these beta-lactams plus this macrolide. And these are also the alternative regimen wherein instead of giving your macrolide, you can substitute it with your fluoroquinolone in the form of levofloxacin and moxifloxacin. So for the D symptoms, so these are now the high risk, okay? And you have to look into are there risk factors also for MRSA or drug-resistant Pseudomonas aeruginosa, because this is where you will add also your coverage for MRSA in the form of your vancomycin or linezolid, or focus on drug that has good activity against Pseudomonas aeruginosa, and these are your piperacillin, cefepime, ceftazidime, imipenem, meropenem, and astronam. Okay, so some of these are we're now doing, and we're giving this to our patients based on the risk factors that are present in our patients. Okay, so you just have to take note of how we dose this antibiotic specifically for Pseudomonas aeruginosa without ESBL risk. If there is ESBL risk in your patients, meaning there is a history of antibiotic receipt for the past 3 months prior to admission, IV antibiotic, then empiric treatment will be the use of meropenem, 1 gram every 8 hours, and imipenem, 500 milligram IV every 6 hours, though this is non-PNDF formulation. So if you're thinking of covering for ESBL, Enterobacteriaceae, and Pseudomonas aeruginosa empirically, then these are your drug of choice. What if the patient develop hospital-acquired pneumonia or your ventilator-associated pneumonia? So currently, since we don't have yet the local PSMID PCCP guideline for that, we are following the 2017 Philippine National Antibiotic Guideline. Okay, so I think most of you are familiar with this, that for any patients with hospital-acquired pneumonia, there are two factors that you have to include in your that will give you this recommended antimicrobial. One is the patient stable? Is the patient had likelihood also of MRSA? So if none of this, then if your patient is stable and no risk factor for MRSA, then you can give a single formulation or single antibiotic in the form of piperacillin, cefepime, or meropenem. Now, if the patient is not at high risk of mortality, but with risk factor of MRSA, then uh, you can combine this gram-negative coverage with your vancomycin or linezolid. Now, if the patient has higher risk of mortality, meaning they are ventilated in respiratory distress, then with risk factor of receipt of antibiotic for the last 3 months, then a combination of your 2 gram-negative coverage in the form of your beta-lactam plus an aminoglycoside or a fluoroquinolone, and then you have to add your anti-MRSA agent in the form again of vancomycin and linezolid. Be sure also that when you have patients with moderate to high risk pneumonia, particularly those in the severe form of your COVID, you have to also extract blood culture in order to document the presence of bacterial infection, and at the same time you do examination of respiratory specimen for culture and sensitivity, aside from the usual workup for any COVID patients. Now, duration of treatment using this antibiotic is also important, and we have already mentioned in the past guidelines that you don't need 10 days, 14 days, or 21 days of your antibiotic. The shorter you give your antimicrobial based on clinical improvement or biomarkers in the form of your procalcitonin, the better for your patients, because they may not harbor or prevent antibiotic resistance. But there are selected population in which you need to also give a longer treatment duration of your antimicrobial. And among these are those who are severely immunocompromised, or if your isolate is highly antibiotic resistant pathogens like Pseudomonas aeruginosa, carbapenem resistant Acinetobacter, or carbapenem resistant Enterobacteriaceae. And most of the time, if you have this microorganism, you also have to add your second line antibiotic treatment in the form of your colistin. I would like to show this rapid microbial identification and what is its role now in COVID-19. The fact that we are able to identify that a superimposed bacterial infection is possible, and yet most of us experience that we were not able, or the culture using your sputum, using the conventional diagnostic modality in the laboratory may not be enough to detect this microorganism. So they have suggested a very important modality of diagnosis using your molecular technology. Why? Because even the fewest number of the organism can be detected with this technology. And these are your multiplex polymerase chain reaction, your MALDI-TOF, and then your whole genome sequencing. Although some of this may not be available in the Philippines, but there are already big centers that are also carrying these diagnostic machines that can identify bacteria. Even with a less number of amount, they can also identify that aside from COVID, that you focus on identification of the virus, you also have to send specimen for the presence of the secondary bacterial infection using these rapid diagnostic testing modalities. And you have a very good yield, and part of the antimicrobial stewardship, I think this is one way also of eliminating the hit and miss empiric treatment with this highly broad spectrum antibiotic, because it can also be a determinant for drug resistance in our patients. Now, before I'll end, and I just like to show you here, uh, there's this question: can CT chest finding differentiate a bacteria from a viral pneumonia, particularly coronavirus? Okay, so this is an updated chest CT findings among coronavirus, and there were three authors who collated this data, and these are the different CT findings. You have the ground glass appearance plus consolidation. So most of those that have COVID, uh, 78% have ground glass appearance or a consolidation. Okay? And I think it's a matter of involvement, which lobe is, how many lobes are involved, that somehow is the determinant of a coronavirus over that of purely bacterial infection. But again, the question then is, what if both of these are present? So just to give you some examples of this, the utility of the CT scan, in fact, they use it to predict mortality with a sensitivity of 85.6% and specificity of 84.5%. So these are some of the classic findings of patients with COVID. Here, this is a 50-year-old woman with a mild form of COVID-19. You have the ground glass opacities, both in the upper lobes, subpleural region, and are centrally distributed. Then the opposite end here is the more severe form of your COVID-19, which is among patients with ARDS. So this is a typical image of a white lung in an 89-year-old presenting with respiratory distress. So you'll notice that you have ground glass opacities, 75% of the lungs that is being involved. So meaning, if you have this involvement, you also have a higher risk of mortality. Okay. Another case that I would like to show here, these are typical findings of a patient with COVID pneumonia. But if you look at this case, the result of the first and second RT-PCRs were negative. So meaning you have a higher sensitivity here among patients with these typical CT findings over that of your RT-PCR. So they did a third RT-PCR, and it turned out to be positive. So meaning, if you have a patient that is clinically compatible with COVID and the chest CT is really characteristic of COVID, even if the RT-PCR is negative, then you have to treat that patient with a COVID regimen. To differentiate COVID from that of bacterial pneumonia, these are the typical CT findings of a patient with bronchopneumonia, a 55-year-old male. And you look at this, there's a tree in bud pattern, okay? And then this is also in the lower lobes, mostly in the lower lobes with segmental consolidation. So as I know most of you have seen also consolidation among your patients with COVID, but with this one, I think the most classic feature of the CT scan here is it involves the lower lobe, and then there's a tree in bud pattern in this particular CT scan. Another patient with the bacterial pneumonia, still with a ground glass opacity, limited in the posterior and lateral segment of the right lower lobe. Then was also associated endobronchial secretions. Okay, so I think this is my last slide. So in summary, among COVID-19, there's a group of population at risk of higher mortality. And these are your patients with older age group, those initially presenting with severe clinical stage and presentation. And that's the importance why understanding the clinical course in order to anticipate late or and early complications, including secondary bacterial infection, is vital to the outcome of these patients. Antibiotic will still play a pivotal role in this pandemic. We're using it as preemptive treatment of secondary bacterial infections because it's very difficult to distinguish between viral pneumonia and bacterial pneumonia. But we need to think that when we are giving our antibiotic, we also have to follow um, the effective antimicrobial stewardship in order not to increase risk also of drug resistance. Okay, so at this point, I will give now the floor to our next speaker, Dr. Jubert Benedicto. Uh, we've been friends for almost 20 years now during our PGH days, and he's one of my closest friend in the PCCP, and he finished his critical care training at the Department of Respiratory and Critical Care Medicine in Singapore. He's also the chair of the CCU Management Action Team, and I think he's in the forefront also now of the COVID Referral Center, which is UPPGH. Currently a vice chair of Patient Services, Department of Medicine, UPPGH, and a board member of the Philippine College of Chest Physicians, associate professor of the UP College of Medicine. So, colleagues, it's an honor to introduce this friend of mine, Dr. Jubert Benedicto, who will discuss the other part of the clinical manifestations of COVID, which are the pulmonary complications. Jubert?
Thank you very much for that introduction. And I also thank you for being my ID senior when I was still in training in PGH and for teaching me other things after office hours. For my first slide, I've entitled the talk Pneumonia Challenges in the Time of COVID-19, and I would like to thank Dr. Solante for giving the proper contextual framework for me to discuss pulmonary perspectives, especially basing it on the concept of how we typically approach pneumonia and did it change since we are encountering this pandemic. So I've sub-entitled my talk Musings of a Pulmonologist. So I would like to share with you in the next few slides, basically my perspective and opinion considering what is happening. I do admit that it is still evolving, our knowledge on the disease and how we approach it. And let's say how we typically approach it if it was not the time of COVID-19. And basically, based on these perspectives, there were changes to a certain extent. There were changes to certain extents that might have influenced our practice. And hopefully, it is for the better outcome and for the better management of patients. So just a quick review, what happened pre-COVID, of course, as what Dr. Salante pointed out, it's basically based on certain guidelines which we know of. It has emanated from a lot of expert group. And then during COVID, it's mainly coming from, worldwide advice or worldwide opinions, expert opinions at that. But maybe if you're going to take a look, pre-COVID, our approach to pneumonia is pragmatic to a certain extent. Pragmatic, I say, because we base our approach on the severity at the time of presentation of patients, and this will dictate our subsequent assessment, where to admit the patient, what antibiotics will be given based on the PISMID guidelines or IDSA guidelines. Those are properly placed guidelines based on good trials. And basically, we do have clear objectives in management: when to step down, how to discharge the patient, and how to follow up these patients. During COVID, majority of the time, if it's SARI, severe acute respiratory illness, If the patient has some respiratory complaints, goes to you at the ER, the main dictum or the frame of mind is it's COVID until proven otherwise. And therefore, to a certain extent, that gives me certain discomfort coming from a pulmonary specialist because we might, tend to overlook the typical diseases that we commonly encounter just because we are really concentrating on ruling out COVID. I'm not saying that's wrong, but definitely there may have some repercussions in terms of our management. Course during this COVID pneumonia is quite dramatic. It's quite explosive, as what Dr. Salante pointed out. And to a certain extent, yes, it is unpredictable. We do see patients that we say, madali itong ma-pull out from the respiratory complaints, etc. But then again, 3 days later, they crash. We do see patients, ay nako, talagang toxic yung patient from the presentation. But 3 days later, they begin to recover. And we give everything at this point, even to a certain extent, if they are experimental, they are not based on rigorous trial because it's basically trying to weigh the benefits versus the potential harm. To a certain extent, such an approach allowed certain leeways in terms of our management. Walang magsasabi na mali yung ginawa mo, wala rin naman magsasabing 100% tama yung ginawa mo. But to a certain extent as well, even if it allowed leeways in terms of management, somehow, outcomes tends to be variable. And I will give you certain points as far as that sentence is concerned. So the main challenges from a pulmonary perspective, and this is coming from my personal experiences in the front line. Number one, history-wise, initially there were clues. COVID to, hindi to COVID. Basically, we are looking at if the patient has history of travel, has been sick, let's say, for the past 14 days, etc., history of contact, etc. But because of that community transmission, nothing became specific anymore. And so the boundaries between saying this can be explained by a COVID or non-COVID disease entity became murky to a certain extent. Number two, bacterial, as what Dr. Solante pointed out, or even viral can coexist and should be covered, even if empirical. Studies, epidemiologic studies have shown us that if you're going to do routine cultures, 22 to sometimes 32% of these patients may have other viral infection, and therefore you might have to have antiviral agents on board. And yes, some patients, they are able to culture bacterial pathogens that you need to cover, but in some cases, because of the presentation, you cannot afford not to cover with bacterial versus bacterial agents. And therefore, you now go back to your template. Is it moderately severe? Is it severe high risk cap? And then you manage accordingly. Number three, inflammatory markers can be non-specific. We usually argue during our pulmonary endorsements in the morning, certain inflammatory markers, syempre mataas yung LDH, you see ferritin more than 300, you see C-reactive proteins, which is at least 100, and you begin to wonder, hey, can this be explained by, bacterial pathogen? Or can this be COVID? And therefore, I need to cover with hydroxychloroquine or chloroquine. X-ray and HRCT findings at the onset can be a little bit tricky. So we will be seeing patients, we will say, obvious ba na TB yan? Obvious ba na bacterial pneumonia yan? And then we sometimes, when you look at their clinical course or progression, sometimes there is a disparity between what the patient feels, what the clinician see, and what the X-ray or chest imaging is telling us. And therefore, there is some discomfort in that particular situation. And you have no choice right now but to cover both for possible COVID pneumonia. That means invoking on a lot of these experimental agents. And on top of that, you need to give the patient a broad spectrum antibacterial or antibiotic regimen. And then you just follow them closely throughout their course. Once the patient would need oxygen supplementation, that will be some challenges and really puts the pulmonologist on his toes. Basically, this is the main question we are asking: to intubate or to wait a little bit more. Basically, at the start of this pandemic, way back in March, we were quite aggressive in terms of preemptive intubating these patients. But studies have shown us that, being intubated and being attached to a respirator is an associated risk factor for mortality. And therefore, even if the patient is quite bad, let's say when you encounter them, we do give them certain leeway. Previously, hindi namin matolerate yung mga 85, 83% oxygen saturation. But then again, we still give them, let's say, high flow, nasal cannula, and then possibly just looking at their O2 sat, okay lang yan mag-wiggle-wiggle between 85 to 88. Hopefully, in the next 2 hours, they will improve. We went back to proning. Proning became sexy. And because there are some articles as far as proning is concerned, we do give them even awake proning. I know there are survivors who really say that proning was the one that did wonders for them. I'll discuss this a little bit later. So it becomes challenging to a certain extent. And Dr. Salante is right. We pulmonologists always go back to what the guidelines are telling us, knowing fully well that guidelines are evolving. A lot is not evidence-based, and therefore we do secure consent from our patients when we give them this quote-unquote experimental interventions. We gained a lot from sharing of center experiences, and I would like to thank the various centers which opened their webinars, their Zoom meetings, even to specialists outside their centers. There were a lot of sharing between professional groups, and we valued those learnings. Because what Dr. Solante pointed out previously, it was PUI, PUM, and possibly COVID. Right now, it's confirmed, probable, or suspect case. That's the main lingo right now. So it's just going to be number 3 first. Confirm if the patient has PCR, RT-PCR, which tells us that yes, patient beyond doubt is a confirmed case. Probable if a swab was taken and therefore it can be inconclusive, or the patient underwent such testing but not in a national or in a subnational reference lab, or when the testing could not be performed for any reason. So it just became probable. All the rest, suspect. And as what I've mentioned, andun yung letter A sa suspect, all SARI cases. But remember this phrase, where no other etiology fully explains the clinical presentation. So during the pandemic itself, pulmonologists are being called to the ER, sir, this is SARI, we are trying to rule out COVID. Then you look at the patient, you're saying this is typical TB, tapos mukhang nagpneumothorax because you have reduced breath sounds in one lung field and the patient has, a really acute onset. Few hours prior to patient's presentation, patient just became dyspneic. Therefore, the patient was labeled as COVID suspect. But I was telling those at the emergency room, this can be just pneumothorax. Lo and behold, based on the X-ray, it was indeed pneumothorax. There can be, some slowness in terms of the management approach, whereas pre-COVID, you might have done needling on such a dyspneic patient, but because it is during the COVID era, you have to don your PPE, then you have to, of course, give the proper intervention. Again, I'm not saying it's wrong. I'm just saying that at the back of our minds, please don't lose the non-COVID possible disease explanation. Number 2 is the definition of contact. In the PISMID guidelines, it's quite explicit. If you have contacts, that means with the health worker being in the index case for, let's say, at least 15 minutes, less than a meter apart. Majority of the time in COVID referral center hospitals, lahat na lang daw sila feeling nila contact. Kasi nga raw yung air daw sa hospital, etc., might carrying COVID and lahat sila bale contacts. And therefore, they health workers, may not necessarily be comfortable going home, let's say after even administrative duties in that hospital. So this is the main shift, old classification to the new classification, like what I mentioned. And remember, we still have non-COVID cases that can go to the ER because of certain other disease entities. Please do not forget to, of course, give them non-COVID management as well. So Dr. Solante has already pointed this out. From the pulmonary perspective, I would just like to highlight majority of the time we are just looking at this one. If the patient has an O2 sat less than 93, an RR of at least 30, can be that the patient is hemodynamically unstable. Definitely that means you really have to be aggressively intervening for the patient. And as what he mentioned, this will dictate if the patient goes to the ICU, goes back to the community or isolation, or goes back to, let's say, a ward setting. Dr. Solante also pointed this out. I would just like to highlight the ones in blue that we pay particular attention to comorbid condition. So medyo mababa yung threshold namin. Let's say if the patient is at least 60 years old and has these comorbidities, etc., we automatically tend to admit the patients as they come because as what he mentioned, this may be the ones associated with an ill course for the patient. This is just a diagram looking at in a in a diagram manner what he mentioned as far as A, B, and category C and D. You can see as well that there's a, of course, preference for possible chloroquine or hydroxychloroquine and possibly as a second line na lang, yung lopinavir and ritonavir. And we agree with the PISMID statement that we tend not to use your chloroquine or hydroxychloroquine in the context of prophylaxis. Really, studies are still wanting as far as that utility is concerned. Okay. So in general, majority of the time, as what Dr. Salante mentioned, these patients, para silang naka-template. They go to the hospital and majority of the time, once they are labeled, even let's say as COVID probable or COVID suspect, they get the following diagnostic. So CBC, BU and CREA, 12-lead ECG, ABG, and of course the culture studies like what he mentioned. We tend to look at inflammatory markers. And definitely, if we cannot rule out COVID, majority of the time, these patients will be given on top of their broad-spectrum antibiotic, possible N-acetylcysteine, vitamins, especially those rich in vitamin Z and zinc, possible oseltamivir. Previously, it was automatic for PGH to cover for with oseltamivir, but right now, it's not automatic. And then possibility of giving the patients chloroquine, possible tocilizumab, especially depending on the what phase you are catching the patient. And as what I've mentioned, lopinavir and ritonavir. We are co-managing these cases with infectious disease service. And I would like to highlight that, of course, communication is very important, especially during this time, because you have to decide minute per minute once you see the patient. Okay, pulmonologists are being called once the patient would need oxygen supplementation. So we have a lower threshold for PGH once the patient is dyspneic, labeled as SARI, or the patient would be warranted to be placed on intranasal O2. We are telling our ID colleagues to please call the pulmonologist on board. So majority of the time, when we are called to manage the patient now will be hooked now to face mask and it is really aggressively being pumped up. So from 5, 10 to 15 liters per minute. If the patient will not respond, we are quite fortunate to have high flow nasal cannula in our setting. So we give them 20 liters per minute at least to not more than 30 liters per minute. Possible non-invasive ventilation. It was previously frowned upon because they tell you NIV can generate aerosol and therefore it might be hazardous to the healthcare worker. But I will show you later on an innovation which made possible this NIV. Preemptive intubation. So that means even if the patient was still awake, We think that the patient, as what I've mentioned, has a disparity between what he's telling us. He will tell us, you know what, doctor, I'm okay, etc. His O2 sats hover around 90 to 93, but you look at him, you see that he's using accessory muscle use. He's quite tachypnic, having an RR of at least 30. Then we already raised the possibility of intubating that patient. Of course, it is a rapid sequence intubation done by our anesthesiologist. Once the patient is intubated, yes, we place him on MV settings and then possibly give them an optimal PEEP. We will tackle this a little bit more in detail. We are quite fortunate that our current ventilators have these possible features, giving an airway pressure release ventilation mode, APRB, or bi-level settings. Uh, and then possibly, of course, once the patient is intubated, we give them adequate sedation. We prefer dexmedetomidine plus possibly, let's say, propofol or midazolam or fentanyl, and possible paralysis if we have difficulty in ventilating the patient using atracurium. And then prone ventilation. As what I've mentioned, it became sexier during this time. So even when the patient is awake, so we have prone patients on face masks, we have prone patients on high flow nasal cannula, and in a number of patients, we were quite successful in having their oxygenation improve. So this is the high flow nasal cannula. So it has a different set of cannula, and what this setup will give you is heated and humidified air, and possibly your inspiratory demands is decreased because it can better meet your elevated peak inspiratory flow demands. It has that possible action, increasing your FRC, likely by a delivery of PEEP. So it has that ability to stand open your airway. It is lighter, and basically, majority of authors will tell you it is basically because of the washout of dead space. And therefore, we are anchoring this management of giving the patients at least 20 liters per minute, so high flow rates, because it is the one that leads to the washout of this dead space. So these are the prone pillows. Yeah. So previously, an ENT specialist, Dr. Remulla, developed this with the section or the division of pulmonary medicine in PGH. We just improved its design. So pinalakihan namin to para sa mukha ng patient. And then we got some slits para kung intubated yung patients, the ET tube will stick out at the side kasi hindi mahirapan yung nurses. Okay? This is one of our consultants, Dr. Kristan. What she did was a scuba mask. So she developed this with some of our expert para pwede yung non-invasive ventilation, and then hindi mo ma-aerosolize yung any secretions of the patient. So you have two-way valve. May papunta, may palabas. So there's no mixing. And in fact, you can begin to see waveforms even with this gadget. So it was quite effective. We can use external PEEP as well. Okay, so I'm going now to my last slides. So basically, the main challenge for us clinician, as what Dr. Salante pointed out, pag nag-ARDS na yung patient, you have to take note that from this Gattinoni article, they look at patients who have severe disease, hypoxemic, yet not fulfilling entirely the usual traditional definition of ARDS because compliance was not reduced. Compliance was not a problem. And this is what Gattinoni pointed out, that there seemed to be an impressive non-uniformity as far as the insult of COVID-19 in the lungs. Majority of the time, you have to consider three factors that will dictate how will your patient present. Basically, it's the severity of infection and host response. So that means depending on the physiologic reserve of your patient, the patient may, present differently at the emergency room. The ventilatory response of the patient. I've mentioned the disparity between our PE and between the subjective reports of the patient. Please rely more on your PE if you need to pump up your oxygen supplementation or you may need preemptive intubation. Time elapsed from symptom to presentation of at the ER. In PGH, let's say the median that we got from the time that the patient had symptoms to the time that they presented at the ER was around 10 to 11 days. So as what Dr. Solante pointed out, these are the ones who can potentially, turn sour in terms of their course because roughly saying we are already at the second week of the time of the illness already of COVID-19. Gattinoni had this phenotype, what he termed as type L and type H. So flash before you are the CT scan. This is from the same patient. Previously, the patient just presented with these findings. So as you can see, majority of the time, the distribution is interstitial and you have ground glass appearances uh, located more at the subpleural areas. In this particular case, when you have this type L because you have low elastance, that means you have high compliance, you have low VQ. Majority of the time, these patients become hypoxemic because of what he terms as pulmonary vasoplegia. Your pulmonary vasculature responds not that well to hypoxic vasoconstriction. You have low lung weight and low recruitability. That means the volume of your gas in this particular lungs for this type L phenotype are not decreased. And therefore, for these particular patients, if you go on and intubate them and put them, let's say, on their typical protective lung ventilation strategy, your patient will have what he terms as SILI, self-inflicted lung injury, which is more prone among type L patients. He also recognized this phenotype as type H. So that means if you're not quite careful and then the patient progressed to this particular picture in the CT scan. So this is type H because high elastance, so that means low compliance, high right to left shunt, that means the more perfused areas of your lungs are not well ventilated, high lung weight, and maybe at this point you have high recruitability. And therefore, accordingly, he recommends the following respiratory interventions. For type L, maybe you should be judicious with your high flow nasal cannula or even NIV. For this particular cases, you may have hypercapnia as one of your main problems, and it is for these patients that maybe you can give them higher lung volumes, not the typical 4 to 6 ml per kilo, but maybe 8 to 9 ml per kilo. When you go on and prone these patients because of the low recruitability, they may not necessarily respond to your proning. But as I've mentioned, in some patients, they do respond to proning. Principally, it is probably because we have distributed the blood flow in the lungs, and therefore proning work. And sometimes we do get patients whose secretions we were able to mobilize, and therefore proning work even in the type L phenotype. For type H phenotype, principally when majority of the time these patients are intubated, we do give them protective lung ventilation strategy. That means 4 to 6 ml per kilo in terms of tidal volume. That means being optimal with your PEEP. Yes, you can give them PEEP to, let's say, 5 to 8, in some studies as high as 12. In this particular cases, you may need to sedate and paralyze the patient, especially if you have really non-compliant lung segments. And as I've mentioned, you may now go on and give advanced mode of ventilation like your APRV or bilevel. And in these cases, proning may work because you now begin to recruit the dependent areas of the lung. So this is my last slide. I think as we move forward, we anticipate that pathways will change. As what PSMID has been telling us, we will be coming up again with a revised guideline compared to our March 31 guideline. We do anticipate that more severe to critically ill patients will be referred to, let's say, COVID referral centers like PGH, Lung Center. We also hope to celebrate small victories. Majority of the time, ang nafa-flash lang kasi sa media, yung ilan ang namamatay, ilan ang nare-recover. But I'm quite picky because I would like to look at patients who are extubated or patients who were previously classified as critical and severe and right now more stable. So I really begin to pick those numbers. Overall strain in the healthcare system is palpable already because as I've mentioned, a lot of our healthcare workers feeling nila nagkaroon sila ng contact and therefore they really invoke the quarantine. We hope to get better at prompt and decisive intervention. So usually talaga we're winging it, no? We're winging it depending on the patient's presentation, considering what we know, we try our best in terms of how we, let's say, address the patient's symptomatology and how we address the patient's problem. And lastly, I really hope to have those decisive steps to address our non-COVID services. Let's not forget about them because they still go to our hospitals. We hear a lot of cases that are being turned down by other hospitals, and maybe this is a good step as well to for us to see how our non-COVID services are affected because we seem to really pay particular or really heavy attention to our COVID related services. And with that, I would like to thank you for your attention. Okay, so we now go to some questions. Jean, are you on board already? Jean?
Yes, 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 yes.
Okay, so there are questions here. I would like first to acknowledge our participants because right now we have 115 WebEx participants and 120 from FB Live. So thank you very much for listening to us in this webinar. Jean, there is question in the absence of PCR, when do you suspect the patient to have bacterial community acquired pneumonia, aside from the table that you've showed?
Yeah, that's a very good question because for the past months, we've been having these cases, especially for the moderate to severe COVID. We're looking for biomarkers like a procalcitonin, but even with procalcitonin, we didn't elicit any abnormality like a determinant that you have a concomitant bacterial infection. Most of the time, even with severe critical, the procalcitonin is normal or even less than 0.25. Uh, the WBC count in some of these patients are elevated, and I think that's one of the more common findings that I have that where my threshold for really starting an antibiotic is really low because of the increase in WBC count. Usually, I look at the patient. If it's the patient is already in the severe and critical phase, then there's no question I will give an antimicrobial. Then
No
we
choice
do,
already.
yes,
Bigay na.
bigay na. Then we do culture, uh, and then until such time that the patient will improve, then we are also very particular when to de-escalate. But most of the time, if you have severe critical, we always go all the way like 7 to 10 days until such time the patient will improve.
Okay. I think there's a corollary question to that, Jean, because you mentioned procalcitonin. Do you have data raw as far as, how did really a procalcitonin guided antibiotic mattered in terms of outcome?
Yeah, again, that's a very good observation because if you look at the most of the articles reporting cases in Wuhan and telling us if procalcitonin is a determinant of response to treatment, I think they didn't. In fact, in one data where most patients did not survive, in that particular data of Huang, where 50% had secondary bacterial infection, the procalcitonin was elevated, and it was also a determinant of particular mortality, although not significant enough to be a predictor of mortality.
Okay. I think I can answer one of this question. When do you request actually for chest CT scan? So from the pulmonary perspective, we tend to be prudent as well with the request for CT scan. If the X-ray is already telling us, the typical interstitial ground glass pattern, probably, alveolar distribution, peripheral distribution of infiltrates, we do not readily request for CT scan. We do request for CT scan if there's a disparity between the clinical presentation, X-ray relatively being benign, yet the patient is hypoxemic, etc. That may have implications for us as Pulmo and maybe as ID in terms of giving chloroquine or hydroxychloroquine. So that will really prod us to give this chloroquine or hydroxychloroquine to these patients in that following scenario. We also request for chest CT scan, let's say, to possibly monitor these patients. Let's say if the patient is not responding well despite adequate antibiotic or anti quote unquote COVID regimen, then we begin now to question if there are other things in the lungs that we need to cover. Jean, any thoughts as far as
Yeah,
CT scan is concerned?
yeah. I think you have noticed that in most of our patients who are in the severe and critical stage, and then you have this baseline CT scan that will tell you this is really extensive ground glass appearance. And the third, second, or third, fourth day, the patient did not improve, and clinically you still are giving the antibiotic. My only concern there is would a follow-up CT scan justified in order for us to say prognosticate that after 2 to 3 days, if the CT scan will not change or there will still be extensive involvement, then that is a prognosticator that this patient will have a higher risk of mortality.
Okay. So I think one of the questions, corollary question to that is the use of ultrasound as well. Ang main problem namin talaga sa CT scan, of course, ito na yung from the practical point of view. You have to disinfect as well the CT scan. You have to prepare the facility for the CT scan. And therefore, it's not a straightforward just requesting for them to do it. You have to ask yourself what is it in the CT scan, or will it change my management in terms of what I see in the CT scan. For lung ultrasound, yes, there are studies to tell us that you can go on and do lung ultrasound for these patients. You may have the typical findings, etc. And therefore, for these cases, you may go on and have this modality, possibly a sort of monitoring the patient. But for me, it is not that standardized yet compared, let's say, to X-ray. I think the bottom line here is you have to really correlate what you see in the chest imaging, what you see in the laboratory, and how does your patient actually look like. You have to correlate those three before you decide.
Okay, Jubert, there's a question here. What do we do to patients who remain COVID positive by RT-PCR despite significant resolution of
Improvement.
symptoms?
So
Yeah.
that's for you.
So for one, we know that the RT-PCR is a diagnostic test to confirm the presence of your virus. And based on articles and studies that the more severe the form of your COVID, the longer the positivity of your RT-PCR, meaning the virus is still there, and it doesn't always mean that the presence of the virus connotes that your patient is still symptomatic. No, the only thing there is that even the most important part there is as long as your patient is asymptomatic, clinically improving, even if your RT-PCR is positive, that only means that these are only particulate or artifact that these patients don't have the active infection, but still are positive with the RT-PCR.
Okay, so in that setting, there's a corollary question. May role daw ba yung antibody testing?
Okay, for now, the role of antibody testing is not mainly on the diagnostic part. It can be a complementary diagnostic modality for the RT-PCR. But I think the main usefulness of your antibody test is you get the IgG. That is the determinant for recovery and the late phase of the infection. So as long as you don't have the IgG, so like for example, if your RT-PCR is positive and your antibody is already IgG positive, then you know that this patient is already in the late phase of the recovery. Now, if your RT-PCR is negative and you have an IgG positive, then that's a good sign because you have recovered from the infection. Now, if you'll ask me, does the presence of IgG indicate immunity? It may, but we don't know how long it will last, and we don't always look at it as an antibody that indicates immunity. It indicates that your patient has recovered.
Well said. I think I will just answer the last question on steroids. Basically, I think we are giving steroids. I know that infectious disease specialists are not fond of giving steroids, but for pulmonary specialists, it's still a big debate. But personally, I do give it if I feel that the patient is at that phase na yung may cytokine storm. So I do give it for that indication, not necessarily for, for ARDS. When we do give it, we give it short course. So that means approximately 5, not exceeding 7 days. And we do use methylprednisolone. So with that, I think I will now close the session. Again, thank you very much for our attendees. It is really quite heartwarming for us to see this many attendees in our first webinar session. Thank you very much to MSD for the partnership with the Philippine College of Chest Physicians, and we do invite you to future webinar sessions. Jean, any final word from your end?
So first of all, I would like to again congratulate all of us frontliners. We are already in the third or going to fourth month of the pandemic, and we're seeing some light at the end of the tunnel. I think we have flattened the curve, but that's not our objective. Our objective is really zero case in the next few months.
Okay. Again, for the attendees, we will appreciate it if you're going to answer our evaluation form. This is for the improvement of future sessions. And I close this by saying that for pneumonia vis-a-vis COVID-19, I think we only not right now begin to know a little bit as far as this COVID-19 is concerned, how they, behave, etc. And we still know we still have a lot of elbow room as far as enriching our knowledge, as far as, let's say, doing clinical trials for this quote unquote experimental drug. But as what we have mentioned as frontliner, I think I'm one with Dr. Salante in saying that we really just do our best with what we have where we are. Thank you and good evening to everyone.
Hindi pa niyan